Good afternoon again. In this presentation, I'll try to stick to time, and I'll be presenting a study about the impact of diabetes knowledge and diabetes and glycemic control. Again, I have nothing to disclose. My objective will be I'll have some introduction, then I'll talk about the methodology of the study that I did, and results, then I will have some point of discussions, then I'll conclude. So if we look at the IDF, International Diabetes Federation, the 6th edition that was published in 2013, about the diabetes prevalence and the expected number to grow, we're expecting an increment of 55% and by 2035. And if you pay a close attention, there has been an estimated increase in all over the continent. But most of the area that will have the most dramatic increase, up to 100%, is in the Middle East, North Africa, which is the area we are, or at least I live in and I practice at. And if you look at this, the top 10 country, I think countries in the Gulf area still competing with some of the countries that were less known and have less economy than those countries. So in Saudi, it's been estimated that it's ranked number 7 by 24% of the people having diabetes. And I think this picture is maybe underestimated because we don't have a lot of research. And again, Kuwait and Qatar, they are not that far from us. But if you look at the 2035, our rank will be worse, where instead of the 7th country, we'll be the 6th country. And it's not good to be in this list, but anyway. Again, 2 of the Gulf area country will remain in the list, so 3 out of the 10 will be there in the list. Okay, so this is an even more recent study, which I do like the most because it's nationwide cross-section. It was done recently. What they did in this study, they checked their the individual fasting blood glucose. They look at different areas in Saudi, and what they found that almost 1/3 of the Saudi population do have some component of dysglycemia. 2/3 were having impaired fasting glucose, and 1/3 of that 30% do have diabetes. And unfortunate, but as expected, even the expected was higher than this, 6.2% were unaware about their disease of whether pre-diabetes or diabetes. And if you look at age category, like I wouldn't call this elderly age, but in Saudi that's almost 40% for those who's above the age of 45 do have dysglycemia, compared to 25 for those above the age of 30. And this is even scary, like 30 is still young, and we're still seeing a lot of numbers in those population. Type 1 only represent 6.6 of the total number of diabetes. So this is a graph, just the orange line is we're seeing the prevalence as a percent, and we're seeing the age group down here. If you look, the type 1 is kind of steady. But if you look at type 2 and the impaired fasting glucose, there is a rapid increment increase after age of 45 and, between the age of 25 and 45. So it's kind of a big increase at younger age. And if you look at this map of Saudi Arabia, because I like this study because it has been done and divided the Saudi according to the regional area, unfortunately where I live at, which have the highest incidence of diabetes of 43.4%. So in Saudi, we live at the top 10 country in diabetes prevalence, and at the area that I practice, we're actually having the highest prevalence of dysglycemia between pre-diabetes and diabetes. Okay, so I like this slide because if you look at the IDF, the 6th edition, when they talk about the prevalence, they have this picture in that slide. So relationship between physician between patient and care provider is an essential component for patient to benefit from the controlling disease as well as preventing complication. We do a lot of medication prescribing, but we don't talk to patient that often, and that's something has to be improved. So what did we do? We designed a study that was cross-sectional in design that evaluate and assess the knowledge of diabetes in patient who has diabetes. And we assess how much those diabetic are not only aware about their disease, but rather how much of them they are aware about complication. We included any adult patient whom they have type 2 diabetes, any men and women. We excluded gestational diabetes and type 1 diabetic patients. We looked at a tertiary center, which is kind of disappointing. So we're looking at tertiary center with the endocrine clinic. Not all providers, they are qualified. Some of them, they have resident. Some of them, they just have 1 or 2 years of diabetes training. But there is also a nutritionist, dietitian, and diabetes educator. We collect the data through the personal interview because we have to ask them the question to assess their knowledge from one of the researchers. We did not approach them. They actually were the same patient. They are coming to clinic. We offer them the chance to participate, and whoever agree, we let him end the study, and he doesn't have the contraindication or the exclusion criteria. The question that we used for assessment was a validated questionnaire. It's called Diabetes Knowledge Test, DKT, which is there's an original version and there's a modified version, both of them validated to test the diabetes knowledge in diabetic patient. Those were developed by the Michigan Diabetes Research Training Center. Those diabetes knowledge tests consistent of 18 questions for all diabetic, and there is an extra 2 questions for anyone who is on insulin. So if patient is on insulin, he will be answering 20 questions. And if he's not on insulin, he will only answer 18 questions. And anyone who scored more than 65 based on other study has been validated. This is consistent with good knowledge about diabetes. We use that cutoff. So anyone who used answer 12 out of 18 or 13 out of 20 were considered to be aware about the disease. So we had 200 patients participated. With fair distribution between men and women. Mean age is 52, plus or minus 13.7. Majority were married, and almost half of those patients has considered to be low income. We fairly took the group that they have, I wouldn't say not educated or literate, but rather poor educational level. So 65% of those obtained only high score or less. So we're not dealing with educated individual. And 1/3 of this population actually have college degree or higher. So 50% were having the disease more than 10 years. So 50% of the group that we're talking to, they've been living with diabetes for longer duration, which is something that we have to understand, because we think that the longer that you live with the disease, probably the more awareness you should have. But that wasn't the case totally, right, in our case. So majority were above 10 years. They were in different regimen, but almost everyone were in oral plus or minus insulin. Mean A1C for this group was 9.1, and mean BMI was 31. And the mean answer question, if we took all sample, that was 47.95 percent. So by having that, the only 22.5% of the population that we screened are aware according to the criteria. So only 22% answered more than or equal to 65% of the question correctly. And the question weren't hard, it's just assessing the knowledge. And I'll show you how much is it easy and how much we are lagging behind. So if you look at this big table, you're going to have the entire cohort and the group that is considered to be aware, which is 22.5, and the group that is not aware. So almost everyone is not aware. And yes, they tend to be younger, but not statistically significant. Male tend to be more aware compared to the female, and that was statistically significant. Educational status do affect the awareness, and more people on the aware group have college degree or higher. No significant difference between BMI. Yes, glycemic control get affected by the level of awareness that the patient has. So people who are aware, they tend to have lower A1C than those who aren't aware. Not only A1C, but even the systolic blood pressure, the total cholesterol, the LDL, and the triglyceride. All the possible measured cardiovascular marker tend to be lower, and the HDL is a bit higher than in the not aware group. So those who are aware, they tend to have more male predominant, more educated, lower A1C, and non-statistically significant higher or better cardiovascular marker, including blood pressure and lipid panel. So those who aren't aware were more likely to be in the low-income group, tend to be older, and have longer duration of diabetes, which is kind of disappointing. Despite this longer duration, patient is not educated. Okay, so we'll go over some of the question, Just imagine, like we ask them, what does A1C do reflect? Does it reflect your past week blood glucose? And 50% doesn't know anything about it, and 25% doesn't, only 25% answered it correctly, so they said false. It does reflect 3 months. But majority, which is 75%, either don't know or they say it's correct and it's not. 50% in the study population doesn't know what is A1C. No one ever told them that something exists called A1C. And if we look at the even more horrible, like there was only there was only 1/3 of the group answered this question correctly, which they said false. We asked him, do you think the Diet Coke can recover your low blood glucose, treat blood glucose? And 1/3 they said false, which is correct answer. So only 1/3 answered correctly. The rest will take Diet Cola for managing hypoglycemia. This is really bad when we talk about education. If patient does not know how to look or how to treat hypoglycemia and doesn't know how to look into for long-term complication, I think we are not doing a good job by treating those patients. And no wonder their A1C is all over the place. Okay, and this is even take it to another step. This is not how frequent or how prevalent those complications in those patients. We are actually just talking about how much does diabetic think that it affects the eye and it affects the kidney or the nerve or the heart disease. So almost everyone in the awareness group, they answer, they think they know that the diabetes affects their eyes, but only 69% they think it affects the eye, which is all of this are statistically significant. So if you look at the aware group, almost 84 plus, they know about some or all complication. But look here at the group that's not aware about diabetes related question. They have no fund about diabetes knowledge. They also are not having any awareness about the possible complication. So they think that it may not affect the heart, neither the kidney, nor the nerve, nor the eye. Okay, so we have limitations, cross-sectional design, sample size, because we don't have a lot of cooperative patients. They were willing to come to the study. We assess only single center, so maybe that is a bad thing from perspective for research, but I think it's a good thing to see that tertiary center is failing to control those or to improve patient knowledge. We should have more strategic plan and attention for those with type 2 diabetes in general, but maybe elderly group, those with low income and low school education, they should have more attention from the clinician. Comprehensive care, multidisciplinary care, including dietitian, educator, pharmacist, clinician, and I would stress more on improving the quality of those trained people, because in our clinic we do have a lot of nutritionists, a lot of educators, but some of them actually misleading for patients. I have seen some of the educator tell patient to drink juice on a daily basis. I don't think this is bad on them, but they are not trained. So we should have a good qualification in order to improve patient care. So what do we conclude? Majority of the patients that we screened are willing to talk. They have poor fund of knowledge about diabetes. This patient with poor fund of knowledge have higher A1C and non-statistically significant worse cardiovascular marker. They are not only not aware about their disease, they are not aware about the possible complication of the disease, which could put them in a high risk for psychological disturbance whenever they have the disease, because they are not expected. Again, 50% of the study population doesn't know what is A1C mean. And in that, I'll conclude. And if you have a question, one or two, I'm happy to answer. Otherwise, we'll move to the next presentation. Thank you. Yeah, so there is actually in the same city, we do have 2 diabetes centers, both of them in tertiary hospital, but unfortunately they don't talk to each other. A lot of patients, they come to both institutions. I think the patient talk to each other, but the physician don't. I think we have a lot of resources, but if we don't probably use them, it will vanish one day. So I think better utilizing of the resources is important. I think there is a lot of misutilization from the patient as well as from the physician. Number of patients has to be reduced. Yes, tertiary center, but in this clinic we see one clinician do see 24 patients in one session.
The referral criteria for patients from secondary to tertiary is not clear for us. Is there any clear referral criteria to be referred to your center?
Not really, but there is no clear criteria. If patient met, he will be referred. But in general, those poorly controlled on their A1C more than 8.5 should be referred to the diabetes center. Because diabetes is so common, there is a lot of people who are practicing diabetes care. They are not qualified to do it. And some centers, they are not supervised to do it. So there has been many problems, even in primary care in Saudi. I don't blame them because they haven't got the training, and they don't let them to go to intensive courses. But there is no clear, your short answer is there is no clear cutoff, but it's just A1C for clinician if they want to refer them.
Just last point. Oh. Do you aim to compare between the knowledge of patients between the tertiary and other settings, or? I think you won't find much difference, as here in Kuwait we did some comparison study between diabetic patients in different settings. The patient seems to have the same knowledge, the same care, the same services. So I'm not sure that in Saudi are the same situation.
I think we're going to end by having the same result that you have. I actually tried to look into different study has been done inside Saudi and outside to see if those with low prevalence, do they have more education? And the problem with that, you cannot see a study that has utilized the same tool to assess. Some of them just utilize different tool. Even in Saudi, they do utilize different tool. So, but we were thinking to do it in a primary care center. But I'm very sure we're going to see the same result, because I think most of the information our diabetic get is through the unauthorized website or from the other patients. Which is bad on us as a clinician, but that's the reality. Yeah.
Thank you very much.
Thank you very much. Sure.
Do you think that the incidence of diabetes is increasing in the Middle East and is particularly Saudi Arabia?
Okay. Thank you for your question. So she's asking why do we think that, or why do we see increased prevalence of diabetes in Saudi? I think the answer is because the lifestyle. It's so sedentary lifestyle back home. I did many study, and the only thing that we share in all study when we ask them about exercise, that everyone is a sedentary lifestyle. So sedentary lifestyle is one. The second thing that is bad in the Saudi culture, which is the you get a lot of invitation for such delicious dinner like what we have here. But we call it, you get the whole lab, and there is only 7 or 8 people sitting on the lab, and they will finish it. And once you are in that invitation, another person will invite the whole group. So shifting dullness kind of strategy. So you'll end by, at the end of the week, you'll have 7 or 8 invitation. So I think we have to change the culture. Saudi gathering, which is bad also, whenever there is any gathering, it has to be served pastries, cookies, and sweets, and you have to eat, and juice, and everything. So we have to change our lifestyle. And I always tell everyone that if we don't pay close attention, I think we're going to be ending by having all Saudi population has diabetes. I have one of my students who told me that he lives in an area in the southern region of Saudi. He told me that before dinner, they serve insulin, but they don't share the needle. They serve insulin to the guest as part of the gratuity of the inviter. So I think we have to change. We don't have to serve insulin, but rather serve a good food for our population. And this story is not going to end until we take the initiative ourselves as a clinician first. And the other thing, I was talking to one of the patients, that's the third thing. Unfortunate, because a lot of clinicians, when they provide the care, they are obese, they are smoker. How come, what do you expect from a patient when a clinician talk to him about diet and weight, and when he turn around to check his lab, he will see his big tummy? I don't think that will work either. So we have to be a good example for our patient. We have to change some of the bad culture we have, and we have to stick to the general guideline. Otherwise, we're going to win the competition by becoming number 1. Thank you very much.